Emergency childbirth is a perishable skill that can fall into disuse with EMTs. Some may go decades or even an entire career without delivering a newborn, while others could deliver 4 in 1 year. Therefore, it is important to review best practices for emergency childbirth annually. You arrive on the scene for a woman in labor. In addition to a primary assessment and standard history taking, what are some crucial questions to ask the patient? How many weeks of pregnancy have you completed? When is your due date? Has your water broken? Did you see the color or note any odors? Have you received prenatal care? Have you consumed alcohol or illicit substances? Is there any chance that you are pregnant with multiples? Are you anticipating any complications? In total, how many times have you been pregnant? How many living children do you have? Did you experience any complications with your previous deliveries? Are you having contractions? If so, how long do they last and how far apart are they? Do you feel the urge to push or go to the bathroom? If a patient answers yes to that last question, immediately prepare for delivery. The fetus's head is probably pressing on the rectum and delivery is about to occur. If the patient answers your questions in a way that makes you think that delivery is imminent, visually inspect the vaginal area for crowning. After you have made the decision to deliver on the scene, the next step is to prepare for delivery. The patient's clothes should be removed from the waist down. Remember to try to preserve the patient's privacy as much as possible. If the delivery is occurring at home, move the patient to a sturdy flat surface or the floor if she will allow it. Pad the floor with blankets and place a pillow or folded sheet under the patient's hips to elevate them about 2 to 4 inches. You will find it is easier to work this way as opposed to a softer surface like the patient's bed. Support the patient's head, neck, and upper back. Have her keep her legs and hips flexed with her feet flat on the surface beneath her. Women who have delivered before may prefer a different delivery position, like on her side. This is acceptable as long as both you and the patient are comfortable with it. Now it is time to prepare the delivery field. Put on a protective face shield and gown. As time allows, place towels or sheets on the floor around the delivery area to help soak up the body fluids and protect the woman and the newborn. Carefully open the OB kit so that the contents remain sterile. Then put on the sterile gloves. After this, handle only sterile materials. Use the sterile sheets and drapes from the OB kit to make a sterile delivery field. Place one drape over the patient's buttocks and unfold it towards her feet. Wrap the other behind the patient's back and drape it over each thigh. Finally, drape a third sheet across her abdomen. Your partner should be at the patient's head to comfort, soothe, and reassure the woman during the delivery. It is not uncommon for patients to become nauseated during delivery, and some may vomit. Your partner should be prepared for this possibility. You should continuously check for crowning. Some patients, especially those who have had previous children, may experience precipitous labor and birth. When labor is too fast, the tissues do not have time to stretch, and the patient is at higher risk for tears in the perineal area. Monitor the patient's contractions. To measure the frequency of the contractions, time from the beginning of one contraction until the beginning of the next contraction. Also, time the duration of each contraction by feeling the patient's abdomen from the moment when the contraction begins, when the uterus and abdomen become tighter, to the moment it ends, when the uterus and abdomen relax. Encourage the patient to take quick, short breaths during the contraction and rest and breathe deeply between contractions. Crowning is the definitive sign that a delivery is imminent, and transport should be delayed until after the neonate has been born. Allow the woman to push the head out. Use your hands to support the bony parts of the head as it emerges. The child's body will naturally rotate to the right or left at this point. Continue to support the head and allow it to turn in the same direction. Avoid the eyes and fontanelles, also known as the soft spots. Feel the neck to determine whether the umbilical cord is wrapped around it. But what if the cord is wrapped around the neck? This condition is called a nuchal cord, and it is present in 15 to 34% of term births. A nuchal cord that is wound tightly around the neck could strangle the fetus, so it must be immediately released from the neck. Usually, you can slip the cord gently over the delivered head, or over the shoulder if necessary. Handle the cord carefully. It is fragile and easily torn. If this is not possible, you must cut the cord by placing two clamps about 2 inches apart on the cord and cutting in between. Once the cord is cut, you must attempt to speed the delivery by encouraging the woman to push harder and possibly more often, because the fetus will now have no oxygen supply until it is delivered and breathing spontaneously. At the next contraction, the upper shoulder will be visible. Guide the head down slightly to help deliver the upper shoulder. Support the head and upper body as the shoulders deliver. You may need to guide the head up slightly to help deliver the lower shoulder. Once the body is delivered, support the newborn firmly but gently. The newborn will be very slippery. Support the newborn's head and neck in a neutral position to keep the airway open. Be sure to note the time of birth. If the mother is willing and able, place the newborn directly on the mother's abdomen with the cord still intact. This skin-to-skin technique keeps the newborn warm and perfused. The mother's skin provides warmth, while the placental perfusion continues until the pulsations in the cord stop. But what if she doesn't want to? If the mother isn't willing or able to use the skin-to-skin technique, warm and dry the newborn with towels and blankets and keep the newborn approximately at the level of the vagina until the cord has been cut. After delivery and prior to cutting the cord, it is not necessary to suction the mouth and oropharynx to clear any amniotic fluid if the infant is vigorous. If the child is gurgling or showing other signs of respiratory distress that indicate that secretions are obstructing the airway, clear them by gently suctioning the mouth and then the nose using a bulb syringe. Another instance where you should consider suctioning the neonate is if meconium-stained amniotic fluid has been reported or observed. Meconium is the dark green feces that comprises the neonate's first bowel movement. If the amniotic fluid is stained green and has an odor, it means that the neonate had a bowel movement inside the amniotic sac. This usually happens because the neonate is in respiratory distress, so be prepared to assist the newborn with ventilations. Meconium can be thick or thin. If the newborn aspirates thick meconium, significant lung disease and even death can occur. If the newborn has been exposed to meconium-stained amniotic fluid and is not breathing adequately, quickly suction the mouth then nose before providing ventilations with a bag valve mask. During the first minute of life, perform the following 4 initial steps of newborn care. First, airway positioning and suctioning if needed. Second, drying. Third, warming. And fourth, tactile stimulation. These steps should be performed on all newborns. In addition to vigorously drying the newborn's head, back, and body with dry towels, you may rub the newborn's back and gently flick or slap the soles of his or her feet. If the newborn is vigorous with a good tone, a strong cry, and adequate respirations in the first minute of life, then note the first APGAR score at 1 minute and place the baby onto mother's chest for skin-to-skin bonding and routine care. Note the second APGAR score at 5 minutes after birth. The normal respiratory and cardiovascular physiologic responses expected are that the newborn will begin breathing spontaneously within 30 seconds after birth, and the heart rate will be 100 beats per minute or higher. But what if that doesn't happen? If the newborn does not breathe after 30 seconds of stimulation, then begin positive pressure ventilation with an appropriately sized bag mask device at a rate of 1 breath every 3 seconds. After 30 seconds of ventilation, evaluate the newborn's heart rate. If it is absent or less than 60, begin CPR. Cardiac arrest in neonates is nearly always the result of ventilation compromise. Use a compression to ventilation ratio of 3 to 1. If done correctly, you should be delivering 90 compressions and 30 respirations per minute during neonatal CPR. Remember that adequate ventilation is absolutely critical to the successful resuscitation of the neonate. Transport any newborn who requires more than routine resuscitation to a hospital with a Level 3 neonatal intensive care unit. The umbilical cord typically stops pulsing about 30 to 60 seconds after delivery. After it has stopped pulsating, place a clamp on the umbilical cord approximately 6 inches away from the newborn. Then place the second clamp approximately 3 inches away from the first clamp and cut between the clamps. Allow the placenta to deliver itself. This usually occurs within a few minutes of the birth, but may take up to 30 minutes. So do not delay transport waiting for the placenta to deliver. Never pull on the end of the umbilical cord in an attempt to speed up the delivery of the placenta. You may tear the cord, the placenta, or both, and cause serious or perhaps life-threatening hemorrhage in the patient. A gush of bloody fluid, usually less than 500 milliliters, occurs before the placenta delivers. This is normal and expected. Wrap the entire placenta and cord in a towel, place them in a plastic bag, and take them to the hospital. Hospital personnel will examine the placenta to make certain that the entire placenta has been delivered. If a piece of the placenta has been retained inside the woman, it could cause persistent bleeding or infection. After delivery of the placenta, place a sterile pad over the vagina and straighten the woman's legs. You can help slow bleeding by massaging the woman's abdomen using a firm, circular, kneading motion with one hand cupped over the top of the fundus and the other above the pubic bone. The abdominal skin will be wrinkled and very soft. You should be able to feel a firm, grapefruit-sized mass in the lower abdomen. This is the fundus. The fundus is the upper end of the uterus. As you massage the fundus, the uterus will contract and become firmer. This may be uncomfortable for the patient. Reassure her and explain that it is necessary to help control the bleeding. Breastfeeding also stimulates the uterus to contract because it causes the production of oxytocin. If the placenta does not deliver after 30 minutes, if more than 500 milliliters of bleeding occurs before delivery of the placenta, or if significant bleeding occurs after delivery of the placenta, the situation has become emergent. Promptly transport the woman and newborn to the hospital. Administer oxygen to the mother, monitor her vital signs closely, and keep her and the newborn warm. Transportation note. Remember that it is inappropriate and unsafe to transport a newborn in its mother's arms. While it might seem cruel to separate the two of them, the neonate needs to be transported in an appropriately sized car seat or on a stretcher restraint system that has been approved for a neonate-sized child. What if you were struck by another vehicle on your way to the hospital and your ambulance rolled over? You might think that will never happen, but it does. And the result could be a child fatality that was completely avoidable.